All right. Well, it looks like we're getting everyone kind of trickled in, so we'll go ahead and get started. We know it's the evening for everyone. Thank you guys so much for joining our wonderful caregiver webinar here at Bierman Autism Centers. We have the lovely Kylan Turner here to present tonight, and she's got really great information and tips to share. We will monitor the chat for any questions, and then for anyone that wants to listen again or maybe isn't able to attend the whole webinar, we will send out a recording tomorrow. So I'm going to hand it over.
All right, thank you so much. My name is Kylan Turner, and I'm here to talk about behavioral interventions to address sleep problems. I can't take credit for this snazzy title here. The team at Bierman came up with it, and sort of kicking myself for having given this talk so many times, but never having such a snazzy title. But yes, I hope that we accomplish this. I hope that you can sort of rest assured with some new information tonight. So I'm going to start with just a little bit about me. Here's, an introduction that you can feel free to read, but really I wanted to sort of orient you to how I came to discover the behavioral interventions to address sleep problems, especially for the population of autistic individuals, little kids, how to support caregivers through this challenge. So when I was in graduate school at the University of Pittsburgh, I worked at the Children's Hospital there in the Autism Center, and helped out with various behavioral interventions we were delivering there. Usually folks were getting referred there for feeding problems or pretty severe disruptive behavior, and they were being admitted to the hospital. And one of the things that kind of came up universally was the fact that caregivers kept saying, "My gosh, my child doesn't sleep." And they were describing pretty profound insomnia, all the way to sort of less severe, a little bit more mild issues, but still taxing that child's sleep at nighttime. So I started talking to my research advisor about that and said, "Gosh, like what's going on with this? We see it across every single patient that comes in, every single client we work with." And I started looking at the literature, and there were a lot of little tiny studies on single subject designs, studies on just a very specific sleep problem and how a behavioral intervention was used. So I'm a behavior analyst. I'm not a medical doctor. And so I was particularly interested in how was it that different clinicians throughout the scientific literature were able to address these very specific issues? And what if we made a manual that combined each of those little interventions to create what's called a broad-based intervention package? And so that became my whole doctoral dissertation. And I worked closely with my research advisor, Dr. Cynthia Johnson. She has edited a book on behavioral interventions to address sleep problems. I think it's mostly geared toward practitioners, but perhaps families might appreciate that too. So my orientation as a behavior analyst has always kind of been focused on families, I've worked in home-based settings for a long time. But I came about this whole sleep world in a little bit of an unconventional way. And I like to tell people that because one of my big, passions is letting people know that, we can, as behavior analysts, address sleep problems. And so that's kind of the focus of tonight, is spending some time talking with caregivers who may be dealing with this challenge. I want to talk first about the behavioral caregiver training model, talking a little bit about the what that is and evidence supporting the model, thinking a little bit about cultural and ethical considerations as it relates to addressing sleep problems, and then we'll get into the meat and potatoes of addressing sleep problems. I can't promise that tonight we will cover the sleep issues that your family or your loved one might be experiencing, but I would like to give you a good broad overview of sort of the direction to take. Something I see a lot in the clinical world is families aren't sure who to turn to. And that's fair. There are a lot of professionals in your lives. And I would just like to make sure that I'm doing my part in letting folks know that medication does not need to be the first line of intervention. For many folks, it may need to be an eventual consideration, an eventual solution. But there are behavioral interventions that are specifically designed and have been shown to be effective to address sleep problems, and it's pretty helpful to start there. And it's so we'll talk about that. We'll talk about definitions of sleep problems, the effects of sleep problems. I think we all know those quite well, but we'll go through them anyway. Interventions to address those sleep problems, and then additional considerations along the way. I did try to slim this down to be able to save some time for plenty of questions and answers, but I want to let you know up front that I love talking about this stuff, and you can certainly feel free to contact me to see what other assistance you could get to address this problem. Okay, let me talk a little bit about the behavioral caregiver training model and considerations. So first, actually, the thing I like to do out of the gate is let folks know, we as behavior analysts can help with this. Believe it or not, sleep is behavior, right? It is a skill that can be taught, and we can change it. And we as behavior analysts, one of the things that we do is we use principles of behavior analysis to teach new skills. And we use other principles, sometimes the same principles, to reduce challenging behavior. And so we can do that with sleep, right? We can take a look at someone's sleep behavior, the circumstances surrounding it, the environment where we expect sleep to occur, and we can modify all of those variables to evoke sleep more easily. And then we can look at variables throughout the day and apply what we know from other disciplines regarding sleep hygiene, the way that the body works, our circadian rhythm, and sort of leverage that information into our behavioral model to really change how long someone is sleeping, etc. One of the other reasons that I think behavior analysts are in a perfect spot to be engaging in this sort of intervention is that we partner with families all the time, right? Caregiver collaboration is really what so much of our work should be about. We're here to, work and guide and support families through various challenges. And I'll talk about in a minute how frequently we see sleep problems in this population. So I think it's important that we as behavior analysts are equipped to be able to do this. And I think it's wonderful that you all as caregivers are here to learn more about it. So you might be familiar with this. This is the caregiver training model. It's pretty straightforward. You have a trainer, maybe someone like me, a behavior analyst, who provides you with some training, some support. They collaborate with you, partner with you to identify behaviors that you want to change. And then they work with you to teach you interventions that we would use to make those behavior changes happen. But one thing that's important to recognize is the trainer works with the caregiver, and then the caregiver is usually the agent of intervention. Why is this relevant when it comes to sleep? Well, I'm going to be honest, in all my years of working in sleep intervention, I've never gone to a family's home at 2 a.m. and sat with them and done these interventions. It just was never going to be a feasible model to adopt. Most caregivers don't really want you to be in their house at that hour. And so, it really, a lot of the literature and a lot of the sort of history of the way that these interventions have been developed have been focused on empowering caregivers, training caregivers in these different interventions, but also listening and learning what is feasible, what will work. And so I think this is the most sustainable model for children to sleep in their natural environment with people who would naturally be occurring in their nighttime environment. So hopefully this model makes some sense, but I like to just call it out, even if it might seem kind of obvious, because it does put a fair amount of pressure on caregivers. And I think that that's necessary to call out and to explore a little bit further about what role this trainer would take in exploring the right sleep plan for that child. So a little bit more about caregiver training. There's been a fair amount of research in this area. I've actually been privileged to work with many of these folks thinking about caregiver training. It provides what I love about caregiver training is it provides support for, caregivers as well as the children. So most of these studies are really focused on both outcomes, on thinking, if I jump back up, thinking about what does the caregiver feel as a result of being effective in changing their child's behavior. Do they feel less stressed because now they know how to address these problems that are coming up pretty frequently in their lives? Do they feel more capable as parents and caregivers? And then how's the child responding? If the child is improving, then that helps the caregiver, right? This is a very bidirectional relationship. And so anyway, that's what I like about it, is you really get to help the whole family when it comes to caregiver training. But caregiver training has also been shown to be really effective. So there are a couple of studies that have focused on the decrease of problem behavior and parental stress. And then in particular, I've worked on some studies that have focused on reducing problem behavior around sleep. And that's really where we're going to go. This is my research mentor, Cynthia Johnson. All right, before we go a lot further, I want to talk about cultural considerations. This is something I mentioned to every single family I work with, especially around sleep, is that, I want to make sure that I'm engaging in, appropriate positioning of, my work as a practitioner. I want to make sure that I'm hearing families when they say, we really want our sleep routine to be like this. I can't tell you how many families kind of sometimes admit to me, they feel sort of shameful. They say, we're actually really okay with co-sleeping, as though I have some manual that says, these are the right ways to put your kid to bed. These are the wrong ways, and they're in the naughty column, right? That's not our role as providers. Our role as providers is to, I believe, and I think most behavior analysts would believe, find out, what does your family want nighttime to look like? What are your goals, right? I think all of us would have the goal of having a child get, good consolidated sleep at night. But I think a really big piece of this partnership, of this collaboration, is understanding that there isn't one way to do things, and that most of the time, families are sort of just doing what they can do to get through the night, get through the week. And so it's really important, I think, sometimes to talk to families, and I like to say this in a talk, that, I'm not coming at this with one angle, with one perspective. And so it's really important to be sensitive to that. So I think my main takeaway for all of you as I advance the slides is to recommend that you are upfront with your provider. No provider should ever tell you that what you're doing at nighttime is, the worst thing ever. I think if they're going to make certain recommendations, then they should support it with some evidence. Obviously, caffeine is going to be counterproductive to sleep. So there are some clear, logical no-goes. But I think that, I've actually worked with some families where they say, we live in an apartment, and, our living room is a comfortable spot for our kid to sleep. And I'm actually okay with them sleeping on the couch. For me, if that's where they want that to stay, that's fine. We will work on making sure that he actually falls asleep there and stays asleep there. So that's an example of kind of what I'm talking about with respect to family situations. Finally, nighttime is a really vulnerable period in a family's home. And so we have to be respectful of that and understand that. So I just want to encourage families to speak up about what they want and what they envision for their family. All right, so we'll talk a little bit about defining sleep problems and talk about their effects. So some of the problems that kids with autism in particular display are kind of falling into two buckets. One is difficulty initiating, so difficulty falling asleep, and then staying asleep is the first one. These are called dysomnias in the sleep world. But basically, when we think about difficulty initiating sleep, often our rule is to be able to define that as a sleep problem is if they are in bed and the lights are out, if it takes them longer than 20 minutes to fall asleep once they're in their bed in their comfy spot, then that's a bit too long. Okay, so typically, if you are going to bed at the right time for your body, you want to see someone falling asleep within 20 minutes. If it's much longer than that, then maybe they're not tired enough. Maybe there's something in the environment that could be changed. There are a lot of reasons for that, but that's kind of the cutoff point is, you want to shoot for something around 20 minutes. You want the person to be awake in their sleep spot before they fall asleep there, if that makes sense. So we don't necessarily want to rely on like them falling asleep in one location and then transferring them into their final location for the rest of the night. And I'll talk a little bit about why. So anyway, if someone is getting into their bed and they are falling asleep within 20 minutes, not a problem. If it exceeds 20 minutes, it is qualified as a sleep problem. Maintaining sleep is also a big challenge. We see what are called night wakings, right? So maybe the child is actually just a-okay falling asleep, but then they wake up usually at 3 a.m. or something like that, and they can't go back to sleep. We see that a lot. Maybe you see both of those kinds of versions. And then arousals during sleep that result in sort of like motor movement, things like sleepwalking or parasomnia, sometimes that can happen as well. But what's interesting is that we see this pretty large range of 44 to 83% of kids with autism between the ages of 3 and 15 have 15 years of age have a sleep problem. That big range is mostly due to different methods of different studies and how they were conducted. But either way you slice it, if it's 44% or 83%, we're talking about a lot of kids with autism who are displaying sleep problems. In kids without autism or developmental disabilities, the prevalence is around 25%. So just to give you an idea, it's definitely elevated in this population. And it's most common when the child is younger than 8 years of age. And the other thing that we see is when those issues sort of, if they grow out of it after being under 8 years of age, sometimes those sleep issues recur at different stages in development. So it is beneficial to address these issues early when they're occurring, so that the family's kind of equipped to handle them if they recur. All right, implications of sleep problems. I think no one is a stranger to this, but it stinks to not be sleeping. It's pretty awful. But for kids in particular, this can, if it's a profound enough sleep problem, it can impact their neurological development, their learning, because they're tired during the day, maybe they're napping, maybe they're missing some of their educational experience, and it can impact their memory, and it can impact daytime challenging behavior. I think all of us have experienced sleep deprivation and know what that feels like. And so we want to resolve that for kids. It definitely colors your world when you have that experience. And we think about all the other things that our kids are dealing with, that if we could take this away for them and give them that resilience that occurs when you've had a good night's sleep, it'd be really, really beneficial for them. There's actually a lot of interesting research coming out about treating sleep first. So there are a lot of folks with anxiety or perhaps post-traumatic stress disorder or depression that when given mental health treatment, one of the first lines has been focusing on sleep which I just think is very interesting. It just goes to show you how critical sleep is to your system, to your neurological system and your body in general. Your ability to sort of like absorb shock, if that makes sense, is much stronger when you've had that sleep. It kind of gives you a buffer to all of life's challenges. So I put this here just to kind of give you an idea again of how powerful this mechanism can be for for the way that people move through the world, including our kids. And then, of course, this is a slide that many of you may be able to craft yourself, right? When a child's not sleeping, usually the parents are not sleeping, the caregivers are not sleeping. So, caregivers report their own sleep disturbance, elevated stress, anxiety, and depression, right? It's a really hard next day if you didn't sleep the night before. So that's a little bit of that information in a nutshell. I want to talk a little bit about behavioral assessment, just kind of briefly. This is something that I talk to providers about a lot, but I find that caregivers are kind of interested in it. Like, how do we know all this stuff from these studies? And so there are some pretty interesting ways that we go about learning about what the sleep problem is and how to address it. So, as behavior analysts, we're always trying to find the reason for a behavioral issue, whatever the behavior might be. And so again, that includes sleep-related issues. So, if it comes down to the child refusing going to bed, or waking up at night, we can point to some reasons why that could be occurring. Maybe the child wakes up and they need their parent, and that's considered attention maintained behavior. Maybe they just find going to sleep to be, a chore, and they don't like the activities around going to bed, putting on pajamas, right? Brushing your teeth, things like that. And so we can think about it in those terms. But one of the things, if you're going to go through a process of trying to learn more about your child's sleep problems, your provider is probably going to ask you for some information about what's going on at nighttime. One of my common go-to methods is what's called a sleep diary. And I've taken to making these Google sheets that are shared between me and the caregiver. And the caregiver can just sort of select or write in really quickly, like they went to bed at 11 o'clock last night and they woke up at 6, and there was one night waking at 4 a.m. for 35 minutes or something. And so sleep diaries are really handy, because then when I see the child in the clinic, or if I'm working with them in a remote consult, I can kind of see a pattern over time. Typically bedtime, or typically the time they fall asleep, is 11 o'clock. They're usually waking up at 4, right? I can see that pattern over time and put some information together to address it. Some research studies that I've been a part of, we've had infrared nighttime video, like nanny cams, and we've used things like actigraphs, which are kind of like Fitbits for sleep. I'll skip over this article, but it's just kind of an interesting one that talks about assessment-based interventions. And, I think the most important thing to focus on in these sleep diaries and this data collection process is thinking about the time of the sleep onset. And I want to just differentiate that between the time that you plan for them to have a bedtime. This is an area where I think a lot of families sometimes, they report to me, they feel kind of shameful. They'll say, I wanted the bedtime to be 8 o'clock. I know that, my pediatrician says that they should be in bed by this time. My mother-in-law says they should be in bed at this time. So I try really, really hard for them to be in bed at 8 o'clock, but they're not falling asleep until midnight. And that's important information to share with your provider, because that's a huge chunk of time that they're maybe in bed or being expected to be in bed, or they're in their room and they're not sleeping. So I just want to emphasize, before we go much further, talking a little bit about the difference between intended bedtime and sleep onset. Again, it's really important for your provider never to give you that signal of judgment, right? It's important to understand when they're actually falling asleep, because all of our interventions and our programs are going to have to be focused around that time, not the intended time if there's a big gap And so we want to know about sleep onset. We want to know about behaviors that interfere with sleep. Sometimes there's a huge tantrum about brushing their teeth, and that is the last thing that happens before they hop in bed. And when there's a big tantrum, they get super activated and they're super upset, and then they can't really regulate down, right? They can't really calm down to go to sleep. So we want the bedtime routine to be as extremely calm as possible. Sometimes what we recommend is adjusting that routine to take out some of those trigger moments temporarily, to then make it so that it's as calm as possible. And we'll talk a little bit about that too. So it's also helpful to share with your provider the night wakings that happen, the total sleep, whether the parent needs to be present in the room, or a caregiver needs to be present, also medication administration. And this is a great tool by Greg Hanley. He's a pretty famous behavior analyst. 2005, he published the Sleep Assessment and Treatment Tool. This is a pretty great tool. So let me jump into these interventions. I have two columns here. Antecedent really just means preventive based interventions, and then we have consequence-based. So these are the interventions we use. These antecedent-based interventions are used to prevent sleep problems. Consequence-based interventions are what we do when the sleep problem has happened, when the kid has woken up at a time that we want them to be sleeping. So I'm going to just tell you, it's pretty hard to use these consequence-based interventions. Let me use a common example. Maybe some of you have engaged in toilet training with your child, right? It's a pretty typical thing for caregivers to have to do. So your child goes on the potty, you give them a sticker, right? Or an M&M or something, right? Every time they do the thing that you want them to do, you give them something they like, they're going to do it more in the future. Well, the problem with sleep is that as soon as a kid falls asleep, you don't wake them up and say, great job sleeping, right? You don't, there's not really a way to reinforce or reward sleep behavior. We kind of have to leverage the actual sleep cycle the best that we can. And what we need to do is think about, when are they typically falling asleep now? Meet them where they are with that, because that's our signal of when the body is actually ready to go to sleep. So going back to that example of, I really want them to be in bed at 8, so I put them in their room at 8 p.m., but they're not falling asleep until midnight. Well, midnight is really the signal, right? Their body is telling us we're not tired until midnight. So what we want to do is use all of our antecedent-based interventions to leverage that motivation to sleep at that period of time in the night. So that's how we start. We start by focusing on when they're falling asleep, doing a bunch of programming around that period of time. And then over time, once we have control over the sleep, once we can predictably say midnight it is, we will back up the schedule and have that child falling asleep closer to 8 p.m., right? So we'll talk about how to do that. But all of that has to do with these antecedent-based interventions. I will briefly in this talk go over the consequence-based interventions. Those are the ones that, when the child wakes up, what do you do about it? But I think the most bang for everybody's buck initially is to really focus on these prevention measures for several weeks, get the body, the child's, circadian rhythm into the routine of falling asleep at a predictable time, to leverage those interventions as much as is possible. These are powerful interventions, these consequence-based interventions, but they may not need to be used if you can use all these preventive measures in the first place. So the first one that I start with, and I think in every sleep plan I've ever developed, I've done this. It is that universal and that important to have a positive bedtime routine. Okay. So we always use this when there's bedtime refusal, which is pretty common. I don't know a lot of kids that want to like end their day, right? They're having a great time, they're at home, they're with their family and they're nice and cozy and it's kind of fun to be awake, right? Not very many kids are just like looking forward to just closing their eyes and doing nothing for several hours. So bedtime refusal is pretty common. And definitely in this population, difficulty initiating sleep, delayed sleep onset, so again, exceeding 20 minutes. And usually when there's any sleep problem is when we use this intervention. So what's the procedure? So I start by talking to families, and I'll give you an example in a second, and asking them to create a comprehensive schedule for me or sequence of events of a typical day. I ask them to tell me everything related to the child's sleep behavior. So their wake up time in the morning, how frequently they're napping, how long they're napping, and the location. So sometimes it's in the car, right? That's just real life. Sometimes they're napping at grandma's house, right? All sorts of different information can come up from that nap frequency. What is the official bedtime, like the intended bedtime? And then what is the time when they're asleep? And then what are those typical wake times? And then we just have a long conversation. So I look at their schedule, their family schedule, and especially when caregivers have multiple children schedules that they're juggling, it's really important to understand kind of why the family's, engaging in the routine that they're engaging in. There are going to be non-negotiable aspects to anyone's routine. So this is where, again, culture matters, understanding that your provider just has to hear you when you say, like, we can't move when occupational therapy occurs, right? Okay, we will work on that, right? We can work around that. And then also identifying some of the problem areas of the day related to sleep. So let's see an example of that. Oh, sorry, I'm getting ahead of myself. So once I have all that information as a provider, I will review the guidelines on sleep hygiene. Sleep hygiene is just kind of a term that has been developed to think about all the behaviors and events in the day that promote sleep or deter sleep or, disrupt sleep. So, an example of poor sleep hygiene would be me right now drinking tea at this hour. I'm doing it to, be engaged through this evening. I wonder if I'll pay for it a little bit later. So there's a bad example of sleep hygiene. But good sleep hygiene would be, maybe exercising, maybe 2 hours before I expect to be asleep or something like that. Going outside and getting some sunlight, right, would be beneficial to me. We do other things like we avoid certain settings or people at nap time and bedtime. Maybe there's a favorite uncle that stops by the house and gets the kid all riled up a couple minutes before they're supposed to go to sleep. That would probably be something that you want to restrict. You want to control the environment, right? So sounds, the temperature, how much light is coming into the room. Those are all factors to think about when you're thinking about the bedtime routine and what the individual's being exposed to. You might want to change the order of events. Some families, I actually grew up in a family where we showered at night. It was just a rule, and that was that. And so I think as I'm raising my kid, I'm doing the same thing because it's sort of typical for me. But maybe a shower or a bath really activates the kid, right? Maybe they get sort of hyper aroused from that sensory experience and they're really wired, right? That might be something you want to move to the morning, to happen in the morning instead of the evening, so that again, we're just promoting calm. So changing the order of events might be something you want to look at. Change how you ask or respond. Sometimes kids respond to one caregiver a bit better than another. It happens in every family, in every household. And so if toothbrushing is the worst thing in the world for your kid, maybe have the person who's kind of easier at or has more success at having them do it, be the one to focus on doing it. You can use visual or auditory cues also. So here's a quick example of what I might gather in terms of data from a family. I spell out the time. The family says at 2 o'clock, we pick them up from school and we go to speech therapy. But in this ride, they fall asleep for 30 minutes. Super helpful information. It could be a problem area if I'm looking to consolidate sleep, right? If we eliminated that 30-minute nap, it's possible that we could get some more consolidation, right? We can concentrate the sleep time in the evening and have a little bit of extra time then. So you might want to look at that. So I usually put like problem area or, a question mark there. They have speech therapy, then they get home, there are no demands, they get to kind of decompress. This could be a reinforcer time where they have screens and entertainment. And then there's dinner, they wander around while they eat, and they enjoy a cup of soda. This is kind of an extreme example, but maybe the caffeine at 6 or 6:30 p.m. is a problem area to think about. So they've had a nap, they've had some caffeine. I'm not sure that we're going in the direction of sleep, right? Sleep is bedtime should be sort of a one-way street. So we've kind of energized the person a bit by giving them a nap, not giving them a nap, but having the nap be there, by having the caffeine be there. Bath time is a struggle, right? They're very hyper after. So now we're kind of moving up, we're ratcheting up. And I share this, I think, when we look at this, it can feel pretty obvious. I share this as a fellow parent, as a person who recognizes that most of my job as a behavior analyst is to be a second set of eyes, right? I'm someone else looking at the day with you kind of objectively and looking for very specific things that stand out to me as things that are going to help sleep or hurt sleep. And so, I think this can be an exercise that you can even do on your own to some degree. I think until we take a look at how we spend our time, it's not always clear to us, what that actually is doing for that end goal. So the last thing I want to point out here before I move on is, they are in their bedroom watching TV. Again, could be a potential reinforcer that we might want to leverage in the future, a potential reward for them. But they're there at 7:15, and then there's this gap where they're in their room and they're playing, and then they're not actually falling asleep until 10:30. I don't, unless the family is concerned about it, we can eventually work on moving them to the bed. But the fact that they're falling asleep here at 10:30 is something that we might want to think about because there's a big gap there. So I'll just show you kind of an example of a positive bedtime routine I might make here. So again, I want to meet the child where they are. They're falling asleep at 10:30. So I want to start with that, and I'll show you in a second where that appears on this plan. But their body is falling asleep at 10:30. So I'm going to make bedtime at 10:10 p.m. And I often hate to say this to families because their eyes bug out. They're like, you want me to, have my child not sleeping until 10:10? But, this is kind of where they are currently. We will try to get them up to a more reasonable hour to fall asleep. But we have to kind of meet with them where they are to be able to create the right routine to evoke sleep. We want to get kind of control over their sleep, and then we can move it up in the timetable. So this child's named Sam, and I'm going to show you the plan that we came up with for Sam to be in bed by 10:10 p.m. So I usually put this information down first, and then I back it up to identify what time we actually start the bedtime routine. So we want him in bed by 10:10, falling asleep within 20 minutes, and that should work because he's usually falling asleep at 10:30. So he's going to have his mom sing a song, and that's going to be the last bit of the bedtime routine. So moving back in time, what I tried to do is starting at 8:45, we do some exercise, right? Then there's some books and quiet activities, a snack to make sure that they're not waking up from hunger, brush teeth, and then they do the song, and then they're in bed by 10 p.m. If this is reliably occurring for like a week or two, and I see that 10-10 is something, that is good, you can turn out the lights and they're falling asleep within 20 minutes, we would bump this up by about 10 or 20 minutes. And we'd say, okay, now we're going to try to see if we can start this routine earlier by 10 or 20 minutes and have them sleeping, at the desired time earlier in the night. But the key is that what we're creating here is a chain, is what we call it in behavioral terms. We've found activities that are calming, that are kind of moving in the direction of going to sleep, that work for the family. And then, basically what's going to happen over time is Sam is getting this pattern down. Sam is understanding, oh, I'm getting tired, right? And by starting the routine later, you're kind of concentrating those very specific routine stimuli for him, and it's going to evoke sleep. It's going to cause sleep to happen. And then you can just start the routine a little bit earlier as you move along. Hopefully that makes some sense. And then here are some other recommendations. Limiting the nap if you can. I know that's really hard when you're driving, so sometimes that won't happen. Moving the bath to the morning, stopping screen time 1 hour before they're expected to go to sleep. We know a lot about the blue light from screens being challenging for people to go to sleep after, and then eliminating soda in the evenings. Okay, so that was the main intervention I wanted to jump into, and then I want to see if there are any questions after I go through a couple more of these sort of tips. So one thing to just keep in mind when it comes to night wakings and it comes to difficulty falling asleep is that we all wake up at night, and we wake up and we don't always remember it because we're actually pretty good at putting ourselves right back to sleep. And we are able to do that because we've become experts on what it takes to get ourselves back to sleep. So this is a little exercise I like to do with families, is just to illustrate this point. Here's a very nice hotel room. Maybe it reminds you of, a vacation you want to take or a vacation you've taken. But when you check into a hotel room, it's an unfamiliar place, right? But you kind of do what you need to do, hopefully, to be able to fall asleep. And what are those things? For me, I don't like a lot of comforters. I like the temperature to be pretty cool. I don't like a lot of light. So I go around the room when I'm getting ready to go to sleep in a hotel room, and I make it the way I want it, right? I make it the way that I need it to be to evoke sleep. Well, kids aren't great at this, right? And I think, as we get older, we get better and better at it because we are more tired and we want to evoke sleep. So what we need to do when we think about how kids are falling asleep, what associations they're making with the items and the sensory aspects of everything around them, is we need to take note on what it takes for them to fall asleep. So I'm going to show you some pictures, right? Maybe for these little brothers, it takes being side by side, okay? And if one of the brothers gets up, the other brother can't go back to sleep, right? So what happens is maybe initially they fall asleep next to each other, but one gets, I don't know, overheated and they get up and they move to mom and dad's room. Then the one who's left there, he wakes up because the natural sleep cycle will have him wake up periodically, and something's different. His brother isn't there and he's alarmed. So he wakes up and he's awake for an hour, right? Until brother comes back, or mom or dad, or, grandma, grandpa, anybody comes back to give him that body heat again. So here, what's happening is that, we've kind of created a circumstance where he's reliant on that. And if that's always going to be the case, that he's always going to have somebody sleeping in bed with him, great. The nights that he won't have someone sleeping in bed with him, he's going to struggle. So I kind of aim for minimalism when it's possible, right? We want it to be possible for both of these kids to, not require a lot of stimuli, a lot of sort of requirements to fall asleep and stay asleep. I worked with a child who needed to line up all of his trains before he fell asleep. And if they got bumped, he was always worried about them getting bumped. And so if he woke up in the night, he needed to check that the trains were okay, and he'd go back to sleep. Here's a child who, is kind of snuggled in their parents, and you can just sort of take a snapshot here of what they need to fall asleep and stay asleep. So what we typically do in these situations, again, is think about what it takes for them to fall asleep. What are they touching, grasping? What do they have in their mouths when they fall asleep? All of those things that are present at the time that they're actually initiating sleep are going to have to be replicated when they wake up. So let's go back to the hotel room and think about the fact that we walk around and we arrange the hotel room to work for us to fall asleep. Well, we're actually all pretty good experts if we slept through the night at rearranging that pillow to get it just right, right? Making sure that if the temperature changed, we can change it back. We want kids to be able to replicate exactly what it is that they need to be falling asleep. And if it's a lot of stuff to replicate, we want to reduce how much is going on there. So we'll want to first identify what it takes for them to fall asleep. And then we want to identify where we want to go, right? So if they need a person present to be asleep, and the caregiver says, I really would like to go back to my own bed, I don't want to sleep in my child's twin size bed anymore, then we work on that. And so we create a systematic stimulus fading plan or shaping plan, depending on which direction we're going, to go from having the parent laying next to the child with a teddy bear to the body pillow and a teddy bear, and sort of systematically start fading some of those stimuli. But it's really important to just recognize that that's usually why night wakings occur, is that the child is literally trying to replicate whatever it took for them to fall asleep in the first place. Their body's naturally waking up. They're going through their sleep cycle. Usually, if it doesn't take a lot for them to replicate, they wake up, they look around, everything's fine, they go back to sleep. If they wake up and brother isn't there, they wake up for good because they're startled. Or they wake up and, their teddy bear has fallen off. They wake up for good for a while. And so our job is to try to figure out what those things are, how to maybe change them to be more sustainable and minimal for them to sort of seamlessly fall back asleep. I talked a little bit about bedtime fading. And so in this case, we just sort of adjust the schedule. I talked about that in the positive bedtime routines section. And again, we want to focus on adjusting by 10 or 20 minutes at a time to bump that schedule up. But again, this is about meeting the child where they are, where their body is naturally falling asleep, and then bumping that chain of the bedtime routine up. Okay, you can take a look at this. This is just another example. All right, and I think I will just close with like 2 more minutes, and then we can open it up to questions and answers. So I'm going to talk a little bit about just extinction. And actually, I'm going to jump down to the one that's a little bit more acceptable to families. Usually when I'm talking to practitioners, I talk about the principles, and then I jump into the practical guide here. And so what we call graduated extinction in the sleep world is really just checking on your child on a time-based schedule. And this is something I would recommend that you do with a provider's guidance. So if all those previous interventions that I just described, the positive bedtime routines, the sleep association, shaping and fading, as well as the bedtime fading, don't have a strong effect after several weeks of solid implementation, you may want to explore this. And so the idea here is you tuck your child in, you say goodnight, and you leave the room. And if the child is prone to coming out of bed and following you, what you do is you set a timer, and you set that timer for a short period of time, maybe 30 seconds. You would work with your provider to establish this. And then you basically go in and check on your child and reassure them on a time-based schedule, not because they're calling out for you, not because they're engaging in other behaviors to get your attention, but because the timer went off. And by showing the child that I'm going to come back on a very consistent schedule, they have very little to worry about after a while. And their attention-seeking behavior at nighttime will decrease. And this often happens with kids who have anxiety, or they're just not used to sleeping on their own. So again, this is just something I would recommend that you explore with a provider. And I think that's pretty much all we have time for. I want to put a plug for this alarm clock. You can also talk to a provider about how to teach what's called discrimination around this. I just pulled this from Amazon. But this, in case a child is having challenges waking up way too early in the morning. And so I think that's all we have time for tonight, but I wanted to open it up to any questions.
Thank you so much, Kylan. Those are great. We did have one question come in. Someone wanted to know, do you suggest melatonin gummies to help aid in sleep?
Yeah, so again, I would recommend that you talk with your pediatrician and the medical professionals in your life about that. I have known a lot of families that have found those to be beneficial to sort of take the edge off, or to assist in the initiation of sleep. And I'm all for that, right? If that's going to be beneficial, again, I just want to put the disclaimer, please talk with the medical professionals in your child's life. Make sure that that's an appropriate choice. Think about dosage, all that good stuff. If that is, something that they recommend, definitely, explore it. But I guess I want to also point out that interesting dynamic with sleep is that, maybe the melatonin helps them to initiate sleep. You want to just make sure that you're training your child to fall asleep in that setting on their own to some degree, if that makes sense. So, because again, they're going to naturally wake up. We all naturally wake up every few hours. And if you don't remember it, it means that you're really good at getting back to sleep. And so if we have the child use the melatonin kind of as a crutch to fall asleep, I think that's great. Just make sure that you've created enough of a standard routine that they can latch on to that when they wake up and need to put themselves back to sleep after another couple of hours. So otherwise you might end up with a situation where they fall asleep beautifully, but they don't stay asleep. Might address half the problem for you, which I'm in favor of, but just recognize that there's that training piece that should happen. And that just comes from consistency with the positive bedtime routine. Oh, I'm looking at this question here. Very typical issue. Yeah, with multiple kids and sharing a room, it can be so tricky. Yeah, so any tips? I have a lot of thoughts on this. And I think I'd love to talk with you about, again, like, what are your non-negotiables here? Or, what is the dynamic? Everyone's house is set up differently, right? And then their preferences as to how close the baby should be to you, in the nighttime and things like that. So you have a 2-year-old and a 10-month-old, and the 10-month-old goes to bed at a consistent time. Yeah. I mean, I'm wondering who has the bigger challenge. Whoever's having the bigger sleep issue, I would start with them in the room. I'm wondering if you could, have the 10-month-old fall asleep in a separate room and then transfer them. But I would love to learn more about that. I think probably I need to know a lot more details on how else to address that. But I think I would start to make sure that they don't interact with each other too much. I would create separate routines with them sort of physically in different rooms so they don't wake each other up while they're trying to fall asleep. But something that you could do is sort of this transfer process. So essentially, if you can find, you know, the blanket that the 10-month-old really loves, and you can create a small sort of mini environment for that 10-month-old to be practicing falling asleep, and then the same kind of salient cues, like very obvious, this is your bedtime space for your 2-year-old. Over time, it won't really matter as long as they're falling asleep with those stimuli. It won't matter if you then take the 10-month-old and put them in the same room, because they should be falling asleep because of that environment and those cues around them to fall asleep. I've known some people to use noise machines in 2 spaces and then just fade down to 1 noise machine, because the noise machine can kind of just like help evoke sleep for both of them once you put them in the same room. It's a little awkward answering your question without seeing if this makes any sense to you, but I hope it helps. Okay, thank you, Danielle.
Right, we have some other questions coming in. One is won't sleep, the child won't sleep with me during the night, checking, you know, if I'm still in bed, interested about the body pillow, but any way to address the checking on me throughout the night?
Yeah, so Renee, yeah, I think the body pillow is your best step first. I think that you know, again, what we're trying to do initially is teach the person to fall asleep with certain stimuli. Okay. And you do that by sort of making, you know, certain stimuli really obvious. So a noise machine is a great way to kind of like have something that transfers across rooms, things like that. Or, you know, the body pillow might resemble you a little bit. I've seen families use a body pillow plus a heating pad, right? You can get creative, but, you know, fading yourself out is going to be sort of a long-term sort of process. The checking on you throughout the night, I have seen folks get like a little toddler mattress or something and put it, you know, a couple of feet away, and the child can check and then go back to sleep. And you just sort of systematically fade your presence out. That's one avenue to take. It's, again, pretty long term. One thing I recommend for families, especially parents who are doing that, is to sort of distract themselves, because it can be awfully boring, you know, waiting for your child to fall asleep. So maybe you get some earbuds and listen to your favorite podcast or something while you just pretend to be asleep. But anyway, there, you know, are ways to address that. I would say maybe reach out to a sleep provider or behavior analyst that addresses sleep problems to think a little bit about how you might also leverage that graduated extinction protocol of sort of having them see you on a time-based schedule. But I think that trying to get yourself out of the bed would be process that you want to do nice and slow and gradually. All right. I don't know if there are any other questions.
I think sorry, I was talking and I realized I was on mute. I think I see one last question come in. Will a medical bed, a cubby, make a huge difference instead of a regular bed?
Yeah, I think it depends on the child. You know, in a lot of circumstances. I'm a big fan of, you know, only going as far as is needed. I think if you create a situation where they're reliant on this very specific type of bed, if they grow out of it, that'll be another point where you have to engage in some transitions and additional training. And maybe by that point it won't matter. But I guess you know, I've seen some families, they know that their child really likes enclosed spaces. I mean, the thing about sleep is that, like, evolutionarily, we're all like cave people, right? Our brains, in order to be able to fall asleep, we need to know we're safe, that, you know, the mastodons aren't going to come and get us, right? Or so, you know, a tent or something like that over the bed is something I've seen. So I think whatever you think could help is, and you're willing to try, is worth trying. I just would recommend that you don't create such a circumstance that you can never deviate from that, or that it will take a lot of intervention to sort of, you know, move away from that. So we don't want the crutch to be so elaborate that you can't reel it back in, if that makes sense. But I think I've seen lots of different creative solutions that the caregivers come up with. And so it really is I wanted to emphasize, it's a bi-directional dialogue here. You know, some of the best plans I've seen have been from families that have come and told me what they did. And it's just, you know, I'm just here to give ideas and some framework here and the basic information to problem solve. So I don't think there are tons of wrong answers here. So,
Thank you so much. I think that about wraps up today. We will send out the recording tomorrow for anyone to listen to, because Kylan gave us so much wonderful information. And with information on how to get into contact with us for any additional questions or anything like that. But we really appreciate everyone spending their evening with us. And if you follow us on social media or on our website, we do these about once a month. So we hope to see you at another one down the road. Thank you, everyone.
thank you. Thank you so much.